Good morning. My name is Dr. Ritu Grewal from the Division of Pulmonary Medicine and the Sleep Disorder Center at Thomas Jefferson University Hospital. What I'm going to be talking about today is respiratory issues in patients with ALS. I have no conflicts for this talk. So as you all know, ALS affects many different muscles of the body. It is a neuromuscular disease, and it can affect day-to-day living activities like turning in bed, walking, climbing stairs. It can also affect fine motor movements and impair handwriting, cutting food, and dressing and performing day-to-day hygiene. Most patients with ALS do not get diagnosed with respiratory muscle weakness until after the diagnosis has been made. And involvement of the respiratory muscles as well as the bulbar muscles can affect the respiratory function of normal gas exchange. And this can manifest in many different ways, like shortness of breath, difficulty lying down, and becoming short of breath, and ultimately it can lead to what we call respiratory failure. In addition, involvement of the bulbar muscles or the throat muscles that can impair speaking, swallowing, and also controlling the saliva can ultimately affect the function of the respiratory system. So to understand how the respiratory system functions, we should first understand the anatomy of the respiratory system. So the anatomy of the respiratory system involves the nose, or the sinuses, the throat, the mouth, which is the lips, the tongue. This back of the throat is very important for maintaining patency of the throat muscles or the upper airway, so air can flow from the atmosphere into the lungs. So from the throat muscles, we go down into the windpipe, and the entrance to the windpipe out here is controlled by what we call the glottis or the vocal cords, and the opening between the vocal cords. And the opening and closing of the vocal cords is very important to facilitate air moving in and air moving out. So if there's any weakness of these muscles, that can impair the function of the respiratory system. From the vocal cords, we go down into the windpipe or the trachea, and the trachea then branches into two tubes called the right bronchus and the left bronchus. And these airways further divide into very small branches and ultimately terminate in these small air sacs, which are surrounded by a lot of blood vessels. And this is where the gas exchange occurs. So for us to breathe properly, we need this entire anatomy to function properly. Now, there's a very important muscle called the diaphragm. This separates the chest cavity from the abdominal cavity, and function of this diaphragm is very important to facilitate that air movement. So how do we breathe? So to breathe, we have to generate what we call a negative intrathoracic pressure in our chest cavity. And to do that, we have to contract the diaphragm. The diaphragm contracts and it flattens out. And then there are these muscles which are connecting the ribs, when these are called the external intercostal muscles. And when they contract, they lift the ribs up and out. And so the chest expands. When the chest expands, we create a negative pressure within the thoracic cavity. So now air can flow in from atmosphere into the lungs. Now to breathe out, when we are breathing out quietly, it is a passive process. The diaphragm relaxes and pushes upward, and so that compresses the lung. The ribs turn down and in by relaxation of those muscles that I talked about. The chest deflates and pushes the air out, but we need this entire throat to be open so air can also go out. Now, when we breathe in actively, which means we take a deep breath in and we blow out forcefully, then we need a whole lot of other muscles to, especially to blow out forcefully, and some of these abdominal muscles come into play. And if these muscles are weak, then blowing out forcefully, as we need to do when we cough, that can get impaired. Okay, so let's expand on this a little bit more. So when we breathe, the diaphragm moves down during contraction. The external intercostal muscles, which are connecting these ribs, they contract. The ribs are elevated, okay? And so there's a change in the anterior posterior diameter, in the superior inferior diameter and the anterior posterior diameter. The entire lung cavity, the entire chest cavity expands, okay? And so air can now flow into the lungs because this negative pressure is created within the thoracic cavity. So air flows in from what we call from atmospheric pressure, which is at 0 millimeters of mercury, and then it flows in from a higher pressure to a lower pressure. To be able to breathe out, the diaphragm moves up. As I told you before, the ribs get depressed as the external intercostal muscles relax, and we are able to breathe out. And that breathing out is very important for carbon dioxide to be eliminated. So the function of the respiratory system is to facilitate air moving from the atmosphere into the lungs. Into the lungs, where the air oxygen is extracted from the air and it goes into the blood and then distributed by the heart into the entire body. Now, carbon dioxide is a waste product of all the metabolism that occurs, and that carbon dioxide needs to be eliminated. So when the blood returns to the lungs, then carbon dioxide moves out into the lungs, air sacs, and by that process of expiration or deflation, carbon dioxide is eliminated. So what happens when we lie down flat? When we lie down flat and we are what is called supine, then the effect of gravity presses all the abdominal contents upwards and presses the diaphragm up. So when the abdominal contents move this dome of the diaphragm up, the lungs cannot inflate as much. Now, the process of going to sleep while lying down flat makes the breathing slow down itself. When we all go to sleep, our muscles relax. We tend to take smaller breaths. And because we take smaller breaths, oxygen levels go down, carbon dioxide levels go up. Now, in some stages of sleep, like REM sleep, then this process becomes worse because the muscles relax even more. So when this is what we call a hypnogram, or it's showing what is called the different stages of sleep as we sleep through the night. So when we first go to sleep, we are awake, and then we go into what is called a light sleep, a semi-deep sleep, and the first third of the night, we spend a lot of time in this, what we call deep sleep. All these stages are called non-REM sleep. So we have what is cycles of non-REM and REM sleep, about 5 or 6 cycles throughout the night. The first cycle is got a very small percentage of REM sleep, but as the night progresses, more and more of these cycles are spent in REM sleep, where the muscles of the body, especially the respiratory muscles, are very relaxed, and the respiratory centers don't respond as well to any changes in oxygen and carbon dioxide. So REM sleep is really not a good time for anyone who has any lung problems or who has any respiratory muscle weakness. The other function of the respiratory system is to cough. So what is coughing? Coughing is a sudden expulsion of air from the lungs through the epiglottis, through that glottis, that vocal cords, at a very, very high speed, so that it can eliminate any secretions that are accumulating in the airways. So normally in our airways, we have a lot of glands that can produce mucus in response to any irritation or any infection. So we need to keep these airways clear so air can flow in and out, and also because these secretions can also become a nidus of infection. So how do we cough? To be able to cough effectively, we need to take a deep breath in. So we fill the air up, we fill the lungs up with air. Then the vocal cords close, okay? So now all that air is under a lot of pressure. Okay, all the muscles are contracting and they make that air to be under a lot of pressure. Then the vocal cords open and we use our abdominal muscles, all our other expiratory muscles that come into play to be able to generate those forces to be able to push that air out. And while that we are expelling all this air, that high pressure will shear off all the secretions that are sitting in the airways and get rid of them. So to be able to cough effectively, we need our inspiratory muscles, we need our throat muscles, that are ones that are opening and closing the vocal cords, and we need all those expiratory muscles that come into play, including the abdominal muscles. So if there's weakness of any of these muscles, then the cough reflex is also impaired. So if the cough reflex is impaired, we use what is called a cough assist device. So it's also called a mechanical insufflator, exsufflator. And what it does is it gives a positive pressure so that the lungs can be completely filled up with air, maximal lung inflation. And then it abruptly switches to a negative pressure, almost like a vacuum. So what it does is it applies this negative pressure to the upper airway through this mask. And so it stimulates the flow and it rapidly extracts all the mucus that is sitting in the airways. So if the cough is impaired because of weakness of these respiratory muscles, one would need to use a cough assist device. So the advantages of the cough assist device is that it basically improves the cough force, the forces that are needed to generate an effective cough. It also stabilizes the breathing pattern, and because it's inflating and deflating the lungs, it can also promote chest wall flexibility. And because it's getting rid of these secretions, it can prevent hospitalizations due to infections. And it can also, studies have shown that it can also improve long-term survival. So what is the progression of respiratory failure in patients who have respiratory muscle weakness? The first thing that it occurs is that there's an abnormal gas exchange during sleep, especially during REM sleep, because all the muscles are so much more relaxed and the respiratory centers are not responding appropriately. And so this can lead to a lot of sleep disturbances that we can see on a sleep study if we do that. Okay, and then as time progresses, it will lead to symptoms of sleep disturbances, like patients will complain of interrupted or non-restorative sleep. They may complain of morning headaches, having a brain fog where the brain just doesn't seem to function as well. One would be tired during the day, be sleepy during the day. And as that abnormal gas exchange progresses to even being abnormal during the day, it can lead to shortness of breath with ordinary activity. Okay, and then patients can also start feeling discomfort when they lie down flat. We call that apnea. And ultimately, it can also lead to a weak cough. Finally, it can lead to respiratory failure where someone is dependent upon a breathing machine to help them breathe both during the day and night. So how do we measure the lung function? How do we know when respiratory muscle weakness has set in? So what we do is when patients come to the ALS clinic, we do what is called a spirometry. And what a spirometry is, the patient takes a deep breath and blows as hard as possible into this tube, which measures the volume of air that is coming out. Okay, there's a clip on the nose and the technician is monitoring it. We can also measure the diaphragmatic strength by doing what is called a negative inspiratory force using this meter. Okay, we can measure how effective the cough is by making patients cough while they're blowing, cough into this, what is called a peak flow meter, and seeing the flow that is generated and then compare it to normals. And there are many different devices. This is one portable device that can also be used. So once the diagnosis of ALS is made, we assess respiratory muscle strength at every clinic visit. And what we are measuring is something called an upright and supine forced vital capacity. And the forced vital capacity is we make the patients take a deep breath in and then blow out as hard and fast as possible. And if the forced vital capacity is less than 50%, then we need to do something about it, because that means that there is impairment of gas exchange. We can also measure the negative inspiratory force, or that pressure generated by the diaphragm. And if the pressure generated by the diaphragm is less than -60, then we know there's abnormal gas exchange occurring during sleep. Other ways of checking is doing an overnight pulse oximetry. If the oxygen level stayed below 88% for more than 5 minutes, then we know that there is a problem. And we can check blood gases. If the carbon dioxide level is high in the blood, then we know that there is a problem. But what we normally do is something that is relatively easy to do when patients come to the clinic, is measure the forced vital capacity, measure the negative inspiratory force or the maximal inspiratory pressure, measure their cough peak expiratory flow rate. And then if they satisfy the criteria, we initiate them on non-invasive ventilation using a respiratory assist device. So what is non-invasive ventilation? Non-invasive ventilation refers to the provision of ventilatory support through the patient's upper airway using a mask or a similar device. So this is what it looks like. You may all have heard of a Bipap or a CPAP machine. These are very small machines that can be kept at the bedside, and through a mask that either goes over the nose, sits under the nose, or sometimes covers both the nose and the mouth, it will deliver the pressures needed to inflate the lungs and also to promote deflation. If the respiratory muscle weakness becomes very advanced and someone needs assistance even during the day, we will go to a ventilator. And the advantage of a ventilator is that it is portable because it has a built-in battery. So if someone needs to go outside the house, they can put this ventilator on the back of their wheelchair and they can go out of the house. We can also use multiple modes of ventilation, one for nighttime use, one for daytime use. And you can also do mouthpiece ventilation, which means just sucking on and taking a few deep breaths as needed. And this is what mouthpiece ventilation looks like. It's as needed breath delivery. It's given through this straw or angled mouthpiece. And one can just take a few deep breaths before doing something like eating or taking a shower, or when somebody just is feeling short of breath. And so the benefits are that basically it can enhance the speech, it can promote in swallowing, and it can just affect overall functioning and make somebody feel better that they're not hooked up to a ventilator all the time, and just use it as needed. So studies have shown that when we start assisted ventilation and we start the cough assist protocol and patients use it for more than 4 hours a day, they can live much longer than if they don't use anything. In fact, this one study showed that patients who used non-invasive ventilation and used it for more than 4 hours a day had a 33% lower risk of dying. So in the meantime, when patients do not have respiratory muscle weakness, what can we do to keep their lungs inflated? If they do not need any respiratory assist device, then using an incentive spirometer. This is this little device that patients use after surgery to keep their lungs inflated, and just using this a few times a day can help to keep the lungs inflated. The other thing that one can do is use what is called a respiratory muscle trainer, and that is basically taking breaths against resistance and blowing out against resistance, and just practice it a few times a day to keep the respiratory muscles trained. And again, there's no data for this, but we do provide this in the clinic, and as long as patients don't overuse it, I think it can help. But what's also important is that in some patients, they can actually monitor their respiratory function do these tests at home, doing a home spirometry, and there are some of these devices that are available, and then the data can come to an app, and then you can transmit it to the clinic. I want to leave you with this one last slide, which is to practice good sleep hygiene. Sleep is really important to be able to function well during the day. So it's really important to give sleep a priority. We need to get at least 7 to 8 hours of sleep at night so we need to sleep for 1/3 of the night for the other 2/3 to function well. You want to treat any other sleep disorders like sleep apnea because that can make oxygenation worse. We recommend that you use the bed for sleep and sex only. Avoid any alcohol and caffeine before going to bed because that can impact the quality of sleep. It can also make respiratory muscle, especially alcohol, can make the respiratory muscles, can affect the function of the respiratory muscles, especially the upper airway muscles. We also say avoid long naps during the day because then that impacts the ability to sleep at night. And it's really important to turn off all electronics and to sleep in a dark, quiet room. Thank you.